Hello.
Good evening, Smita.
Good evening, sir. Sir,
Yeah.
you can start the session. I have already opened the.
Okay. Two
Evening,
minutes,
sir.
2 to 3 minutes. Yeah. Right.
Good evening.
Right.
Good evening, sir. How are you,
Good
sir?
evening. Fine. How are you?
Sir, you came to Tirunamalai, sir, last week?
No, I couldn't come. I was not feeling well, so I
Oh,
couldn't. Yeah. I gave an online lecture.
okay, sir. Nice. Actually, I came to Tirunamalai. I thought I can meet you on that day.
Okay. That's it. But I was planning to come up with the ticket and all. Last moment, I couldn't. I thought I will change my plan.
Yes, sir. That's fine, sir. Yes.
We'll start in 2 minutes time, Mathu. We'll wait for 2 minutes and chat. I think I'll start now. So, good evening to all of you. As usual, I will start with a short case first, then go into a long case. Then subsequently, if time permits, I will show another one more interesting short case. Okay, is my screen visible to you all?
Yes, sir.
Yes, sir.
Yes, sir. Visible.
Okay, so this is a story of a 60-year-old diabetic. Only short history, 5-day history of acute onset of vomiting, giddiness, tinnitus of right ear, and inability to walk with a static course. On the third day, he said he hears every sound as two. This is very short history. 5 days history of acute onset of giddiness, probably vertigo, vomiting, tinnitus for right ear, and inability to walk with a static course. And third day, he said he hears every sound as two. You can just hear the story. He speaks in Tamil, so
அப்போ வாந்தி வந்துட்டு அந்த வாந்தியோட வந்து அதுக்கு பிறகு அந்த காது அடைச்சதும் தலையில ஒரு மாதிரி மர வச்சபடி இருந்து
காது எந்த காது அடைச்சு வருது
he said blocking on the right ear.
சவுண்ட் வந்த மாதிரி அடைக்கிறது இல்ல சவுண்ட் வந்த மாதிரி
அடைக்கல சத்த மாதிரி வந்து
சத்தம் மாதிரி
இப்படி
இறப்பு மாதிரி அது
He
அதுக்கு
said hearing
இப்ப
sound in the ear.
நேரத்துக்கு நம்ம இது பண்ணோம் ஒரு மாதிரி டபுளா கேட்ட மாதிரி
ஒரு சத்தங்கள் டபுளா கேட்கும்
டபுளா கேட்ட மாதிரி
அதுக்கு அன்னைக்கு மட்டும் நடக்க கஷ்டம் இருக்குல்ல
ஆமா கொஞ்சம் லைட்டா தான் இருந்து இப்ப கொஞ்சம் கூடின மாதிரி இப்ப நடக்கவே முடியும்.
Okay, so that's the story of the patient. Let us see the examination findings now. Look at the eye. He has got a nystagmus beating towards the left. No nystagmus of looking to the right side. Not in the primary position. But turn to the left side, it reappears beating towards the left side. No rotary component. There is no nystagmus of looking up or down.
கீழே பாருங்க.
Ocular movements otherwise was normal.
இங்கே
Again, you can make the nystagmus seen on looking on the left side. Head thrust was negative. It is positive on the right side. It can be the positive at the right side.
கேக்குதா?
ஆமா
He could not hear on the right side.
ஒட்டுமே கேட்கல. கிடைங்க. முறுக்குங்க.
Suspicious facial weakness on the right
இந்த
side.
தொடுதலும் தெரியுதில்ல ஒரே மாதிரி. இப்படிக்க போடுங்க.
Parallel movement, tongue
முறுக்கி
movements
பிடிங்க.
normal.
இது முறுக்கி பிடிங்க.
Motor system examination power was normal. There is no gross suspicious incoordination, no definite incoordination of the limbs.
இந்த கையால் உங்களுக்கு பிடிங்க.
Reflexes upper limbs were normally elicited. Lower limb also just elicitable. Plantar downgoing.
உங்களுக்கு ஒரே மாதிரி தெரியுதில்ல?
Sensations were equal on both
ஒரே
sides.
மாதிரி தெரியுதா? சரி. இது தெரியுதில்ல? கிரிகிரிப்பு ஒரே மாதிரி.
Vibration normal. So also joint position sense. With eyes open, he could stand with much problem. The moment he closes the eye, he falls towards the right side. And tandem walking is defective. Tendency to fall to either side, more towards the right side. So that's the story. He's got a right sensorineural hearing loss. Horizontal nystagmus with the first component with the left present in the left lateral gaze. Right lower facial weakness. Rest of the cranial nerves normal. Curry right lower, we are not very sure about it. Then positive head thrust test on jerking the head towards the right side. On standing, patient sways to the right side. Tandem walking defective, tendency to fall to the right side. So where is the localization likely diagnosed in this?
Sir, is there any skew, sir?
No skew deviation, and nystagmus is only on beating the left side or looking to the left side.
Sir, all his symptoms are localized to right ear, sir.
Correct.
Right inner ear.
Right.
Left beating nystagmus also points the pathology to the right ear, sir.
Perfectly right. Perfect. Peripheral look like peripheral vestibular nystagmus. Perfectly right. So what do you suspect in this patient?
Since he is a 60-year-old male, non-diabetic, an AICA territory infarct should be ruled out before we label him as a peripheral vertigo, sir.
Okay, right. Okay, very good. Any other thoughts from anyone?
Vertebral-based stroke with the vestibular nucleus involved.
But he has also got deafness on the right side. A brainstem stroke per se hardly ever produces deafness on one ear.
AICA infarct can produce deafness.
Due to what? AICA is supplying the brainstem will not cause deafness, but can cause deafness by some other means.
AICA also supplies the vestibulocochlear nerve, sir. So
Correct. You have to say labyrinthine artery. The labyrinthine artery, which is a branch of AICA, if it is affected, it can produce deafness. So what I'm trying to say is that if it's a brainstem lesion per se, because the pathways are crossed pathways, auditory pathways are crossed pathways. So if per se your brainstem iliac lesion will not cause deafness. To cause deafness, it has to be in the auditory nerve or in the labyrinth. I mean, not labyrinth, the cochlea. So your diagnosis is correct, AICA infarct, but you have to say it is the involvement is the site. If you want to say the site of lesion, every finding in this patient can be explained by a labyrinthine involvement involving both the vestibular component as the auditory component. Correct? Is there anything against a peripheral vestibulopathy and cochlear involvement?
Right, mild facial weakness.
Yeah, that's a mild facial weakness. If it is there, that is very odd for a peripheral problem. Agreed. That's the point against. Because labyrinthine artery also supplies a facial nerve to some extent. Okay, so all of you think what? AICA infarct or a peripheral labyrinthine infection?
AICA, sir.
AICA, okay. No, you're all right, but why did you consider AICA? How can you negate me as why not acute labyrinthitis? It's got a nystagmus favoring peripheral nystagmus. Head thrust is positive on to the right side. standing, he sways to the right. That's also typical of peripheral labyrinthine. And standing erect. Pardon?
Ethers positive localizes peripherally, isn't it?
Yeah, correct. Locally peripherally. Correct.
Sir,
Okay.
but head impulse test can also be positive in central causes, sir.
Yes.
Head impulse test is not only for
Yeah.
peripheral, sir.
Okay, what is described? So these are I brought the case to bring out the pitfalls in the hinge diagnosis. So if you get a peripheral hinge diagnosis, classically beating to one side, correct? It is not a direction fixed nystagmus. A central nystagmus is a direction changing nystagmus. It changes to, when you look into the left side, it beats left side, into the right side, it beats right side. But you can have a side beating or a direction fixed nystagmus even in a central lesion, especially in lateral medullary infarct. And this is called pseudo-vestibular neuritis. I think this point I have already mentioned many times in my talk. So peripheral nystagmus wise, there is cannot totally differentiate. So that is what pitfall in hinge testing. Second pitfall is that even though head thrust is typical of peripheral, can also occur due to central lesion if the involvement is in the vestibular nerve root entry zone in the brainstem. It can produce exactly a positive head thrust test. The third point, skew deviation, if it is present, it is a very good point for suspecting a central lesion. Hardly ever it is in the peripheral lesion. But the problem is that all brainstem lesion need not produce a skew deviation. If it is present, okay. If it is not absent, it does not exclude a brainstem lesion. So these are the pitfalls in hinge examination. In the patients, that is why we formulate hinge plus. What is hinge plus? The patient is unable to stand or walk without support. That means a real loss of balance, indicating a central lesion. Here it is dubious. He has got real loss of it, only falling towards one side. But his gait is ataxic, that is favoring a central. More importantly, if you have got associated deafness in acute setting, that favors a central lesion rather than peripheral. Theoretically, you can argue that an acute labyrinthitis involving both cochlea and the labyrinth can produce all the same symptomatology. But that clinical scenario is very, very uncommon. In 90% of the peripheral vestibulopathies affecting only the vestibular nerve, that is why the present is called vestibular neuronitis. The so-called classical labyrinthitis affecting both components is rare, occurring in other local conditions like automastoiditis and things like that. So whenever you get a deafness with acute vertigo, in an especially elderly, always try to rule out a AICA infarct, right, central lesion. So that is the point I brought the case. So this is the question. Now let us analyze the problem. Hearing, what is diplacus is due to? Diplacus again, the one sound is heard in different peaks on the same ear. That usually occurs with a peripheral lesion. Nystagmus, this is your typical peripheral nystagmus. Strands fall to the right side with eye closure, can occur peripheral vestibulopathy as well as due to central cause. So the odd point is that one you can say, as Monsar was telling, mild right facial weakness. And gait is, if it's marked ataxia, there is unlikely for a peripheral lesion. So this is the MRI. You can find a vestibular root entry zone infarct there. That location can produce a positive head thrust test when the vestibular nerve enters into the brainstem. In fact, he has also got infarct in the upper medulla and the part of the cerebellum. Also in the lateral part of the pons. Part of the cerebellum. That vertebral artery is not seen on one side. So in fact, what you all said is correct. In fact, in the right lateral pons, medulla as well as vestibular root entries in the pons, hypoglossal vertebral artery, due to the affection of the labyrinthine artery. So this is the answer I want. Here, the AICA infarct is correct due to the vertebral cyst involvement, but the affection is predominantly in the labyrinthine artery rather than the brainstem in this patient. Even though it's got infarct there, the symptomatology is mainly due to the labyrinthine involvement, peripheral involvement. And this is, I was referring to pseudovestibular neuritis. This acute unilateral peripheral and central visual lesion can cause similar symptoms and signs. It is caused by unilateral fascicular lesions in the entry zone of the eighth nerve, vestibular nucleus lesions, or vestibular cerebellar lesions, mostly caused by infarctions and MS. The signs and symptoms may mimic vestibular neuronitis if there are no additional clinical brainstem or cerebellar signs. Skew deviation was the only specific but not sensitive sign in for pseudo-vestibular neuritis. So AICA infarct with maximum apparent labyrinthine artery plus partial lateral dependent. So any questions in that? It's a short case. Any questions? Shall we go to the next case?
Yes.
sir.
Now this, the labyrinthine artery sometimes can act directly by the basilar or it can arise on the AICA. Now this story of a 24-year-old, it's a long case, female. In fact, I had seen her 3-4 years back. History of clumsiness of gait noticed by her peers from the age of 8 years. There may be long history. However, for the last 4 years, patient noticed scraping of her toes while walking and difficulty in putting the chappals. No sensory complaint. She's a vegetarian, I forgot, she's also a vegetarian. So clumsiness of gait, it was worsened and noticed patient scraping of the toes while walking and difficulty in putting the chappals. However, the patient denied any sensory complaints or sphincter problem, no upper limb complaints. The video, look at the video of the patient. The shoulder abductor is normal. Biceps normal. Biceps also normal. These sections are normal. Finger strap is mildly weak, not very sure. Maybe it will also I could overcome that, so I'm not very sure it is really weak or not. Single complexes are all normal. Other small muscles are all normal. Normal power. The pectoralis major normal. External rotators, internal rotators are all normal. Now look at Weber sign negative. Look at the lower limb power now. He's got some edema-like thing in the foot. I'm not sure about it. I was looking for the EDB, but I could not make out the EDB there. Tone is normal. Hip flexion was weak.
Okay. Sorry.
It is weak on both sides. Hip abduction was normal hip abduction. Hip adduction was weak. Not grossly weak, mildly weak. It's weak, definitely weak. Hip extension was almost normal. Vociferation EHL 0 power. Knee extension was normal. Cortices is normal. Plantar flexion was normal power. Plexalis longus also. AHL is 0. Plexalis longus is good power. Adductor pollicis is normal. There is no atrophy. It's from edema. I couldn't make out any atrophy in this muscle. EDP. The knee flexion is also normal power, almost normal. Come to the reflex. Flexion normal. I checked again. Okay. Reflex upper limb just elicitable. Only reinforcement. This make it called 1+. Knee check, right knee check was absent. Even with reinforcement. Left knee check is absent, but reinforcement it appeared. There is present. Right could not, and both angle checks were absent. Reinforcement also saying no angle check could be as absent. Plantar was mute. Checked again, the angle check, just absent. Even the plantar flexion power was normal, reflex was absent. Sensation was grossly normal. There is no abnormality I could make out. Johnson's also normal. Then she was asked to get her from the low-lying place. Found it difficult. With support, she could manage to get up with difficulty. This is how she walked. She got bilateral foot drop. And she could get up on the stool with much of a problem. So infection, she's not that weak at all. So on examination, cranial is normal, motor, upper limb all normal except Corey mild weakness of finger extension, that I'm not very sure. Lower limb weakness of hip flexion, hip extension almost normal. Hip adduction is weak, that is definitely weak. Normal power of knee extension, hip abduction, and knee flexion. Ankle dorsiflexion, EHL grade 0. Plantar flexion, flexor hallucis longus normal. EDB, no hypertrophy. I'm not sure it looks like choreatrophy. DTR, upper limbs all just elicitable. Lower limb, left knee is elicitable after reinforcement. Right knee jack is absent. Both angle jacks absent. No sensory. Gait, step-based gait. Could not get up squatting position without support. So where is your localization and possible etiology you like to consider in this patient? If you want any clarifications, I can provide.
Ankle contractions.
There's no angle. No, I didn't get an angle contracture. Passively, I can dorsiflex the angle not to normalcy.
Is the history progressive, sir, or static, sir?
Progressive, because it started long year. For the last 4 years, it is progressing.
Sir, any percussion myoedema or anything like that, sir, in the edema?
No evidence of any myedema or delayed large. Nothing, just not there in this patient. In fact, she was, even though she's from Kerala, she was actually Tamil Nadu. She was actually studying in Germany. So she was investigating in Germany. That investigation, I will show you that later.
Myotonia, sir.
No myotonia.
The disease is mainly confined to the lower limbs motor axis. not the
Correct.
sensory axis, and there is more distal involvement than proximal. There is both proximal and distal involvement. However, sir, the foot drop suggests that it's a more of a distal involvement than proximal, probably, sir.
Correct.
And there is only mild upper limb distal muscle weakness.
Now that is
Uh,
doubtful. That is not very doubtful.
Doubtful. So there is no frank sensory long tract pyramidal or cerebellar signs.
Correct. Perfectly right.
So probably, sir, muscle disease I would like to consider first, sir.
Hmm.
It's because of the symmetricity of the involvement, and anterior horn cell won't come because there is no cross discernible wasting or fasciculations. So I would keep muscle disease at first, although there it can be a long-standing polyradicular neuropathy as well,
Yeah.
with predominantly the motor radicals affected.
Yeah, why can't be something like a hereditary neuropathy, like a peroneal muscular atrophy, because predominant after is the peroneal distribution, distal muscle weakness more. The other clue is against. I agree with you. Muscle disease is that the plantar flexors are normal, but the angle jacks are absent.
So it can selectively involve the dorsiflexors in case of GNE and all these myopathies.
Yeah, correct. That's correct. I perfectly agree with you. That's a good possibility, myopathy. But the point against myopathy, I was trying to now find out why the angle jacks were absent in this patient with relatively normal muscle power.
Yes, sir. That is
That's the only point. That's the only point against.
Yes, sir.
So you have to keep that possibility also, no? CMT also one possibility, long duration, where the reflex can be lost earlier. Neuropathy, the reflex lost earlier than the myopathy.
Adult onset SMA can be considered.
Okay, in CMD and distal SMA, in fact, both almost same. Hereditary motor neuronopathy, distal type. Again, that's a possibility you can keep in mind. Okay, am I audible to you?
Yes.
Yes.
Yes, sir.
Between the connection, there was some message telling that a connection is unstable. Okay, so the patient came with these investigations from Germany. I will show one by one. There are a lot of investigations. I will show one by one. So these, forget about it. They did a nerve conduction study. The left upper limb median motor, both sides are normal. Okay, so I'll skip that. In the peroneal nerve, the amplitude is decreased bilaterally. More decrease on the left peroneal nerve than in the right peroneal nerve, 0.76 and 0.3. Okay, right tibial nerve, mild decrease in the amplitude bilaterally, again more decreased. This time is more decreased on the right compared to the left side. So the posterior compartment muscle is also affected. This is a summary. These are all from their record. Peroneally pronounced, this is language there, it's not a typical English. Peroneally pronounced polyneuropathy of legs clearly leading to axonal and motor skills. They have converted German into English. Now, what else you need now? What investigation?
Sir, the EMG should be done. Repeat NCS with EMG.
Right. So already they came with, actually every investigation was done. The EMG was done from that in 2021 in Germany. So I'll show the summary. In slide, this is a description. I think it's waste of time looking for the description. It's not a good English also. Slight neurogenic changes in the muscle tibialis anterior consistent with the above mentioned PNP, maybe peripheral neuropathy, I think. So then they did the various autonomic function test. The RR interval was normal. They did MRI, lumbar plexus, normal. They did a CT brain, CT thorax, abdomen, everything was within normal limits. Now coming to the blood investigations, the routine blood chemistry, TCDC, etc., etc. were normal. Peripheral smear was normal. The electrolytes, serum calcium, normal. The only positive finding is a mild elevation of CPK, 161, 341. It's not grossly abnormal. It can be called within. No, it's not 5 times or 10 times more than the normal value. Then TSH thyroid function tests were all normal. Vitamin D was little less. Then creatinine, protein, etc. was normal. Urea was slightly elevated. Then porphobilinogen profile all normal. Now coming to the vitamin B12 was decreased. She was a vegetarian, that is a decrease. So it was 191 to 663, normal range. Here it is 119. B6, B1 were normal. Folate also normal. TPO, thyroglobulin, negative, normal, within normal range. Serum protein electrophoresis is normal. This is the values. They did echo to rule out amyloidosis, cardiac echo. There is no evidence of amyloidosis. Poor soundability. Okay. CT chest abdomen, inconspicuous CT of thorax and abdomen. That's normal. Hepatitis virus negative. They did Borrelia, Treponema pallidum, HIV negative. CSF they done normal parameters. They did neurofilament light chain. They're all within normal limits. Oleoconal band normal. Immunoelectrophoresis again normal. And NFL transcriptase normal. Then OGD, they did, because they are considering the vitamin B12, did OGD, which is again microscopically inconspicuous OGD. Final conclusion, no malignancy, no sprue, no Whipple's disease, no parasitosis, second and third intestinal metaplasia, no helicobacter pneumococcal. This is the conclusion. The serum B12 was repeated on 5/10/21. This is a repeat value was normal. Probably they must have given some injection. Otherwise, it had not gone up to from 114, it has gone to more than 1000. Previous value was 119. It is about 3 months gap. Then other thing, then the CPK was repeated again, borderline 524. The second one, CPK, no, so that's the CPK. No, that is serum vitamin B12. Okay. So gastric biopsy, normal. So they diagnosed axonally motoric leading peroneally accentuated polyneuropathy of the legs, presumably as a result of vitamin D deficiency. AK diagnosis normal. So this is the discharge summary they came with. Now, before going to the discussion, what do you think about their investigation? What is your interpretation? Impression. In fact, the patient has been having disease for many years. Why do you want to do all these blood tests?
So there is no point in doing vitamin B12. It is not related to vitamin B12. Sir.
Yeah, correct. You're right. But that is what they thought. What can we do? Because there's only, see, I'm not criticizing anyone. This is the problem in looking at the investigation and treating the patient. Okay, now the patient is now come to you. She said there's no improvement with treatment. What do you want to do now? All investigations has been done.
There are muscle MRI followed by repeat EMG.
Repeat EMG, okay.
Muscle MRI first.
Okay, right. Any other things that anyone would like to do?
Genetics, sir. Because myopathy or a neuropathy can be only determined based on the gene involved. We had a similar case of cypinopathy, which is a very rare gene, which presented to us as a distal myopathy, but it was actually a neuropathy, sir. So genetics would have a definite diagnosis, sir.
Right, perfectly right. Now, that is not what I want. That is not my approach. What I'm trying to say is that, see, in this patient, first of all, what is odd against motor polyneuropathy? That's the first thing. So two DDs agree with you, motor neuropathy versus a myopathy. But what is against motor neuropathy? Definite point against.
Upper limb is
Intrinsic foot muscles.
Selectivity.
Yeah, that's the point. See, let us the motor examination once again. Weakness of hip flexion, hip extension normal, hip adduction weak. A normal power of hip abduction. So adductors are selectively affected. Hip flexion is affected, hip extension is normal. Dorsiflexion is 0, plantar flexion is 1. So that means it's not a neuropathy you can produce 0 for the dorsiflexion with the normal power of plantar flexion. It's quite odd. How can neuropathy produce the hip abduction so weak with the tortoise normal power? So that kind of a selectivity should make you suspect a myopathy. So this is the selective I'm trying to look at. So what is odd is this already the selective involvement already said. Now I left out one examination finding purposefully. Can you tell me what examination was? Which I did initially but did not show you now because I wanted some interest in the discussion.
Sir, was the EDB bulk spared?
It is atrophied.
Okay, sir.
That is
Nerve
all.
thickening, sir.
Pardon?
Nerve
Neck weakness.
thickening.
I didn't get you.
Neck muscle weakness. Sir.
Very perfectly right. You're right. Just right. Because if you find a neck muscle weakness, there is a point very strongly favoring a myopathy. Now let us see. Neck extension normal, flexion is markedly weak. Neck flexion is weak. That's some point in myopathy. So what is the diagnosis now? It's a myopathy. So I repeated the CPK. That is again not very much elevated. So mild elevation, not cross elevated. Then what else you like to do?
EMG.
Muscle
EMG.
MR.
Yeah, muscle EMG and muscle MRI. Okay, this is a amplitude decrease. That's not going to help us much whether it's neuropathy or myopathy. So EMG was done. So I did the EMG first from the affected muscle. That is from the tibialis anterior. My sound is not coming.
Right.
Sorry, I play once again. Sorry, what is something?
Right.
I'll check one second. Why sound is not coming? Sure. It was playing correctly today morning. Turn up the volume. Not hearing anything. Turn up the volume.
Right.
You know what the EMG showed myopathic pattern from the tibialis anterior, a small amplitude potential, some amplitude of the potential from the interference pattern. Sorry, I couldn't show the classical sound, but I don't. Okay. Now I did for the cordyceps. Again, sound is not there. That is so normal. See the potential size and the good interference. Let me see what is some problem there. I know. Something's happened. Okay. Anyway, in the interest, I will not spend much time on that. Right, TA showed myopathic pattern and cortices normal. Now, what is the diagnosis now?
GNE myopathy.
GNE myopathy. GNE myopathy doesn't classically affect the tibialis, and it can, unlike other myopathy, usually EDP is hypertrophic muscular dystrophies, but GNE is one exception where you can, it's a distal myopathy where EDB can be affected. Usually in distal myopathies, the small muscles are spared. It affects the semi-distal muscles like tibialis anterior, tibialis posterior, long finger flexors, AHL, they will be affected. The muscle which are usually spared in myopathies are, even distal myopathies are EDP and short muscles of the foot, like adductor hallucis. So that's what you can, but EDP was atrophied in this patient. That can occur with GNE myopathy. So what will you like to do now?
Sir, whole
Again,
exome
sequencing, or you can do MRI did.
Yes, sir.
So this is, yeah, MRI did. Now this is the MRI of the patient. I will show the MRI. See, the anterior compartment muscles are affected, and the part of the gracilis, the posterior compartment also is mainly the anterior compartment. I'll show each muscles, the diagram of each muscles later on. Now, look at the picture now. I'll show the normal, the pictorial diagram on the right side and our patients on the left side. Now, this muscle is tibialis anterior. Here, the one on the right side is the diagram. That's a location. You see it has become hyperintense on in our patient. The second muscle is extensor digitorum and extensor pollicis longus. That is the one which is on the diagram, and the corresponding hyperintensity is in our patient. The third muscle is peroneus longus and brevis. That is the one here, and the one you can see the affected one. So it is in the anterior lateral compartment is markedly affected. So look at the posterior compartment, like the calf and tibialis pointed, etc. They are normal. So I will show that muscle also. It's a soleus, bulk of it normal, no hyperintensity. Gastrocnemius is affected, part of gastrocnemius is affected. And that is tibialis posterior flexes, they are also not affected. So this particular distribution is favoring a self-surgical GNE myopathy. This is the, now I took the MRI of the thigh. MRI thigh shows, I'll show the anatomy also, the same, just like the, like I'll show the anatomical picture, a diagram of the thigh also. You can see the posterior compartments of this atrophy here and atrophy in the middle part of the posterior compartment. The cortices is very well preserved.
Posterior compartment.
This is the gracilis.
Hamstrings.
Again, showing the anatomy of this one. That is a vastus lateralis preserved in our patient. Then rectus femoris again preserved. Vastus intermedius normal. Then vastus medialis again normal. Now look at the other muscle now. Gracilis is affected here. That's also one muscle is affected in GNE myopathy. Then coming to the posterior compartment, that's adductor longus, that's also atrophied. You can see that gracilis is affected, adductor longus is affected. Both are adductors. In our patient also, the adductor muscles was weak. Adductor magnus was again markedly atrophied in our patient. The semimembranosus is normal. Semitendinous is atrophied, and biceps also is normal. So some selective group of muscles are affected, adductors as well as the semitendinous is affected. I think hip muscles are there. I think I'll skip that thing. Even our radiologist, even this report to the radiologist, bilateral, near symmetrical, diffuse altered scaliness noted in the muscles of pelvic girdle, thigh, and leg described before. Possibility headache, inclusion body myopathy suggests GNE mutation analysis. DD myofibrillar myopathies. The DD is always myofibrillar, which affected proximal and distal, predominantly distal muscle involvement. So gene testing was sent and GNE myopathy. So as you all suspected, it is the typical presentation of gene myopathy. So the other names are Nonaka distal myopathy, that is inclusion body myopathy 2. I think I'll skip all these things. Few points in the clinical onset, second to third decade. It can range from 12 to 78. Present as foot drop, early peroneal and anterior compartment. Then comes proximal involvement. Asymmetry in some muscles can occur. In the lower extremity, onset in the peroneal. In the hamstrings can be affected, and gastro can also be affected later on. Upper extremity, wrist extension flexion, hands in muscles and grip can be affected later on. They can have scapular winging in some patients. Neck flexor extensions may be weak. Respiratory involvement 30%. The spared muscles are corticeps, spared in most patients. Arms deltoid is spared. Leg, hip muscles, and plantar plexus are spared. Okay. But I think this I will skip. Slow progression, disability within 10 to 20 years. Often beats and big. There are variants of GNE where upper limb extremities early can be affected than the lower limb involvement. Again, the distal muscles are affected first. They can have proximal leg, the hamstring weakness, and no foot drop. That's another type. And can be axial muscle involvement early, and it can need not be early onset, it can be late onset. CPK only very mild elevation, 2 to 5 times in all other things. So the lesson is that no amount of investigation will surpass a good clinical examination neurology. So always give a clinical examination before going to the investigation. Otherwise, you'll be seeing some values in the investigation. You'll be led into thinking the wrong, when you will go into the wrong diagnosis. Okay, you're all right in the diagnosis. So what is your, any other questions in this patient?
Sir, one doubt, sir. Why the knee jerk was depressed, sir?
And
Ankle
that-
jerk, we can.
yeah, you are also very good question. That is why they also initially thought took in that direction. See, always in all, if you look back your cases, there will be some odd point in every case. Okay. See, if you look at if a normal individual, some obese normal can have hyporeflexia by themselves. Lean individual have hyperreflexia, ingress reflexes. So normally also in obese individuals, reflexes are slightly low. I cannot offer an explanation why knee checks are absent in this patient. One side is absent. Why the ankle checks are absent? It's difficult to explain. Because those muscles only partly is affected. Large bulk is not affected. So you don't expect ankle check to be lost. Probably concentration also the reflex is lost. That's all I can explain. Okay. Shall I go to the next case?
Yes, sir.
Okay, one more case, okay? Before that, I will show some interesting findings. See, nowadays the muscle MRI has come into the forefront making a diagnosis. So previously, we all depend upon the muscle biopsy and things like that. One of the conditions which we should not miss is dermatomyositis. It's a very treatable condition. So I show some slides which are typical for dermatomyositis. If you find that, you can, my MRI base, you can make a diagnosis. While proximal muscle involvement is common in both polymyositis and dermatomyositis, MRI can help differentiate dermatomyositis based on specific patterns like peripheral distribution of the high signal intensity and involvement of the fascia and subcutaneous tissue. See, it is the involvement of the fascia and subcutaneous tissue. If it is present, think of dermatomyositis. Dermatomyositis frequently shows high signal intensity in the fascia subcutaneous tissue, which can be a distinguishing feature. Now I'll show some of the pictures here. You can see the focal hyperintensity in the skin here. You can the MRI picture. That's a typical picture of dermatomyositis. Then reticular type of hyperintensity, like in the reticular pattern in the subcutaneous fat. These are not seen in other myopathies. Then again subcutaneous fat again with hyperintense. You can have hypointense calcification in the gluteal trochanteric regions with the rim enhancement of calcification. Then another finding in this is the honeycomb appearance of the muscle. It refers to a specific pattern of muscle involvement characterized by a reticular or net-like pattern of increased signal intensity within the muscle, particularly noticeable in stir and T2 weight images. This pattern is often seen in the context of inflammation and edema within the muscle, facial, subcutaneous tissue. And this is the reticular pattern. You can see that reticular pattern. So the arrow is showing the reticular pattern. These are the features: facial, skinner subcutaneous, peripheral distribution, and honeycomb appearance. This again showing the honeycomb appearance. Now I'll show another case of distal muscle weakness of Hansen's. Can you tell me what is the diagnosis is? This patient came to complain of knee buckling, and this is the hand.
Willander, sir.
Willander is an old term. Nobody knows Willander now. It could, anyway, nowadays no Willander is there. There may be some other name for that.
The Bethlehem myopathy with prayer sign.
But this is he's about 65-year-old man. And what does this hand show? He's unable to flex the finger. Yeah, like this. He cannot do that. So which muscles are weak?
Long finger flexors.
Long finger flexors are weak, correct?
Marcus Griggs and this Willander and all these affect the upper limbs, and also EDMD also affects the upper limbs, I think so.
Yeah. They're all younger age group. He's an
Yes,
old
sir,
man.
young person. Polymyositis maybe.
Why should this selectively affect the finger flexors? And look at
This is IBM, sir. Inclusion body myositis.
Right. See, he has got see the leg now. He has got cannot unable to extend the knee. Marked weakness of finger flexors. He had melted out appearance of the vastae and sartorius. And another important finding in MRI is that in the vastae, the osteomyelitis, the point differentiate between GNE and inclusion body myositis is that GNE cortex is paired. Okay. Upper limb muscles are involved, cortex is paired. Here, corticeps is affected and upper limbs are affected. That's an important differentiating point. Another point is that the distal part of the vastae are more affected than the proximal part. And this is said to be 100% specific for this condition. See, this one, the corticeps itself. Upper part of the corticeps is okay. The distal part is thinned out and wasted and hyperintense. That kind of a wasted, like what you call narrowed down pattern of the corticeps is a point strongly favoring IBM, induced body myositis. Another point, as you already pointed out, the finger flexion weakness. Okay. This another sign called undulating facial sign. I do not know what it is. Okay. But remember that hyperintensity muscle does not always mean myopathy. It can also occur due to neuropathy. But that happens usually picked up in the stir images. Can be seen T2 also, but classically in stir images. Okay, I'll go to the third case. This is a story of a 22-year-old man. History of progressive difficulty in walking for the last 3 years. History of dragging of both feet. No sensory complaints, no bladder problems. History of bilateral defective vision for the last 4 months. So go back to the history once again. 22-year-old man. 3-year history of progressive walking difficulty with the dragging of both feet. However, there is no sensory complaints or bladder problem. History of bilateral defective vision for the last 4 months. So, an examination, I will show you a short video only because I'm not taking the video of the entire examination like the previous cases. High elements were normal. Cranialness, visual acuity was decreased. 6/36 is bilaterally not corrected by glasses. Pupils normal reacting to light. No field deficit. Fundi normal. The rest of the cranialness normal. Motor system, tone normal in the upper limb. Spasticity in both the lower limbs, more on the right side. Power, upper limb, normal upper limb power. Lower limb, distal muscles are weak. Bilateral claw feet was present. DTR, brisk in both upper limbs. Knee jerks were brisk, but ankle jerk were just elicitable. Plantar abdomen. Sensations normal. This is the gait of the patient.
തിരിച്ചു വന്നേ, തിരിച്ചു വാ, ഇങ്ങോട്ട് തിരിച്ചു നടന്നേ, സ്പീഡിൽ വാ, സ്പീഡിൽ വാ, പിന്നെ തിരിച്ചു കിടന്നേ, തിരിഞ്ഞു കിടന്നേ, തിരിഞ്ഞു കിടന്നേ, തിരിഞ്ഞു കിടന്നു.
Definitely spasticity is more on the left side.
More on the left side. തിരിഞ്ഞു തിരിഞ്ഞു വന്നു.
So I'll tell the findings once again. Visual acuity decreased, but pupil normal, field normal, Pandey normal. Spasticity of both lower limbs with weakness of distal muscles and bilateral claw feet. DTR brisk, except the angle jerk, which are normally just elicitable. Plantar abdomen sensations normal. This is the gait. So, what is the likely site of lesion and diagnosis?
But the ankle DTRs were exaggerated.
No. The knee jerks were brisk, angle jerk were decreased, or no, just elicitable. Upper limb movements are also brisk.
HSP plus syndrome, sir.
HSP plus, yeah.
Very good. There is HSP plus is on this side. Okay, and let us analyze the problem in this patient. HSP plus is a good possibility. They can associate decreased peripheral neuropathy, can occur, amyotrophy can occur, that could produce encephalopathy deformity. Okay, but what about the blindness in this patient? Decreased vision. Where is the site of lesion for the blindness?
Sir, it might be optic nerves, sir. We have to look for cherry red spots.
Okay, but the fundae were normal and pupils normal, no field deficits.
Cataract, sir.
There is no cataract. Okay, what investigation would you like to do in this patient with spastic weakness?
CT brain, sir.
CT brain you want? HSP suspecting. Okay, but yes,
Adrenoleukodystrophy is a possibility, sir.
pardon?
ALD adrenoleukodystrophy.
Perfect, that's a good possibility. So, what investigate to do?
MRI brain.
MRI cervical spine.
When the myopathy is the first to do cervical spine and dorsal cord. Okay, MRI, the cervical spine was done. The cervical spine was normal, and this is the dorsal spine. Did you see, what did you see there? Got atrophy of the dorsal cord. See, the upper part and lower part is open, the middle dorsal cord is atrophied. Okay. So, what else you want now? It goes with HSP.
MRI brain, sir.
Why MRI brain po?
Sir, in
Because-
HSP or ALD, we should look for.
Okay, very good. So, MRI brain is there.
Posterior predominant white matter changes, sir.
So, what is the diagnosis?
ALD, sir.
Perfect. Somebody already diagnosed ALS, not ALD, adenomyeloneuropathy. Okay. Usually, adenomyeloneuropathy, this is not the usual picture. They had a hyperintensity in the pyramidal tract, but they can have this picture also, not uncommon. But this is the thing tell you is most likely adenomyeloneuropathy. So in this case, patient blindness was actually cortical blindness due to the involvement in the white matter tract with the oxygen. See, if you all, as you all suggested a brain MRI, if you had not done a brain MRI, you would have missed the diagnosis. I think the coordinator would have straight away thought it is a HSP and then send the patient. Because of the blindness only, we took an MRI which showed this find. Otherwise, you know, hyperpigmentation, nothing was there. Yeah.
Oh, after that.
Pardon? Okay. This is a T1 weighted. This is a sagittal cut. This is from the literature, classical ALD. Adrenomyeloneuropathy is an adult variant of X-linked adrenoleukodystrophy, characterized by ABCD1 gene mutation. Age of onset usually older age group, 28. Progressive spastic paraparesis beginning in the distal lower limbs with hyperreflexia, impaired vibrations, and sphincter dysfunction. Patient can have adrenal insufficiency. Some patients may also experience cerebral involvement leading to cognitive and behavioral changes. The MRI changes are classically spinal cord atrophy, mostly thoracic. There is lack of focal T2 hyperintensity which may relate to indolent disease course. The brain cerebral demyelination may be absent, can be confined to the white matter tracts or diffuse depending upon the subtype. Most common finding in adrenomyeloneuropathy is the T2 hyperintensity along the corticospinal tract, less commonly in the spinothalamic tract and audiovisual pathways. This is from the literature. This is a classical hyperintensity seen in adrenomyeloneuropathy. No, the classical adrenoleukodystrophy, you know, the posterior garlands and all. This is the one usually find in the adrenomyeloneuropathy. So our patient had a picture similar to that of adrenoleukodystrophy. This is another picture from again adrenomyeloneuropathy. Again showing picture simulating adrenoleukodystrophy. So that's the story. So any questions?
Sir, in this can be a possibility of MTHFR gene mutation. Last time we discussed like similar presentation, kind of
Yeah, right.
spastic paraparesis with bilateral symmetrical hyperintensities.
Right. But that picture, the MRI picture was slightly different. And that patient did not have any atrophy of the cord. And usually the methyl tetrahydrofolate reductase deficiency produces not pure motor, sensory also. In fact, the percentage can be very wide also. They can have seizure phenomena, they can have stroke-like presentation, neuropathy presentation. So many things can occur in MTHR deficiency. And if you ask me why not, that's a possibility. But not now, after seeing the MRI, we need not consider that possibility. Okay, any questions? Shall I stop? Go for one more short case.
One more case, sir.
Okay, one more short case. The 65-year-old hypertensive, acute onset of weakness in the left side of the body 1 day prior to admission. Mild improvement after admission. Ultra short case. This is the findings in this patient.
ഇവിടെ നോക്കുമ്പോ ഇടത്തോട്ട് നോക്ക്. ഇവിടെ മുകളില് പല്ല് കാണിച്ചമ്മ. ഈ കണ്ണ് മുറുക്കി അടക്കി മതി. നാക്ക് നീട്ടമ്മ. നാക്ക് അങ്ങോട്ട് എങ്ങോട്ട് കാണിച്ചു? ഇടത്തോട്ട് വലത്തോട്ട് ചലിച്ച്. വലത്തോട്ട് കൊണ്ടുപോവാ. മതി. പറ്റുന്നില്ല. മുറുക്കി പിടിക്കാൻ നോക്കട്ടെ. കൈയൊന്ന് പൊക്കി പിടിക്കമ്മ. അങ്ങോട്ടെ പൊക്കി പിടിച്ചോണേ. പൊക്കി പിടിച്ചോ. ശരി. ഈ കാല് മടക്കിക്കമ്മ. ഇത് മടക്ക്. ബലം കൊടുക്കാതമ്മ. ബലം കൊടുക്കില്ലേ അമ്മ? കഴിഞ്ഞു. ഇത് കഴിഞ്ഞു. നേരെ
Left plantar nerves are going.
അറിയാലോ, ഇതറിയാം, അറിയാം. ശരി.
No cortical sensory loss. Graphesthesia was normal. It's a short case. What is the diagnosis? Nothing great about this case. Now, what is the doubt about it? What is the diagnosis? Acute presentation.
Ischemic stroke, sir. Probably right subcortical pathology,
Correct.
sir.
It's a common garden variety. Okay, so what investigation you want?
MRI brain.
MRI. So there is a diffusion. No acute infarct seen. I'll show the picture once again. This is the aspect upper pons, no? ADC, pons midbrain, flare,
Pons
SW.
normal.
Pardon?
Pons is normal, sir. Some hyperintensity condition.
Where in the pons?
Yes, sir.
Let me see that.
Diffusion.
Here. It's acute, right? This is a flare sequence.
Diffusion.
Diffusion, okay, I'll go to the diffusion.
Okay, this one, sir. Left one.
Here. Okay, is that the one? Does it look acute stroke hyperintensity?
No, sir.
Yeah, maybe.
Diffusion coronal.
Okay, coronal you want, okay, right. So what do you think? Now, what do you like to do?
Sir,
Angiotomy.
was she a diabetic?
She's a diabetic.
The CBG on presentation was normal, sir, or it was hypoglycemic?
No, I'll show you. This is what, I purposely did not show one picture. Where did you see the infarct now?
Yes, sir. Yes, sir. There is.
Yeah, where is it? Not in the pons.
Medulla, anterior medulla.
Medulla, correct. Then how can an antemedullary lesion produce left human facial paralysis?
Sir, the
Aberrant,
facial fibers descend a little in the medulla before ascending.
Yeah, right. So it will produce ipsilateral, contralateral.
So generally should produce same-sided, but in that Olszewski syndrome or something that it is produced.
Okay, what is it is generally correct. No,
Opalski.
you're perfectly right. Yeah. Opalski is the same side, not to the other side. Opalski is the lateral medullary infarct. The lateral medullary infarct is the same side. In the anterior medulla, it is the contralateral side. Why? Because these fibers descend along with the pyramidal tract. Okay. Then it crosses the opposite side, but posterior ascend in the lateral part of the medulla. I'll show the diagram. This is the medullary anterior part on the right side where the pyramidal tract is being formed. See, this is a picture orientation of the corticobulbar fibers to the face. In the fibers in the upper facial nucleus, there is no confusion. It goes to the opposite side and it got bilateral representation. Fibers go to the both sides. Now, as far as the lower fibers are concerned, they descend down, cross to the opposite side, and into the lower part of the facial nucleus, which supplies the lower part of the face. So, right, that is why if these fibers are affected, only you get weakness of the lower part of the face, mimicking a classical upper motor neuron fibers. The lesion need not be here, it can be here or here. If it is here also in the opposite side, here also opposite side, here it is same side, depending upon where these fibers are affected. So in the classical, if the lesion is here, in the medulla, before crossing, you get a contralateral lower facial weakness, just like our patient. If it is after crossing, it produces ipsilateral lower facial weakness. So this is how the fibers are descending. These fibers are coming through the pyramidal tract here anteriorly. Then it crosses to the opposite side and ascend. The descent is anteriorly, descending fibers come anteriorly through the just take along with the other corticobulbar fibers. But after crossing, they ascend posteriorly to the facial nucleus. Facial nucleus is even more posteriorly. Okay, that is why they get caught in the lateral medullary syndrome after crossing. So if the lesion is in lateral medullary syndrome, you get ipsilateral lower facial paralysis. Okay. On the other hand, if there is an anterior medulla, you get contralateral facial palsy mimicking an internal capsule lesion. Okay. Internal capsule. That is, when you get facial palsy, what do you normally say? Lesion above midpoints. That's the classical teaching. But that can also occur with an anterior medullary lesion. That is why this case has been brought. You understood? That the mechanism why a medullary lesion is causing is so-called upper motor neuron parts on the opposite side.
So will this cause an element type of facial palsy or?
No. This is an upper motor neuron type of facial palsy. Because these are upper motor fibers before ending in the facial nucleus. I'll show the picture one second. See this picture. What I'm doing, the cortical fibers here. That is supplying the upper nucleus. Because it could bilaterally supplying both sides. Whereas the lower facial nucleus, they descend down the upper motor neuron fibers. They cross to the opposite side and then enter the nucleus. Element comes only after the nucleus. So the entire thing is upper motor neuron.
Okay.
Since it's affecting the lower facial muscles, it looks like it looks like even the fibers, it looks like lesion above the midpoints.
Yes.
Sir, is there any name for this loop, like Jennery loops, like that, something like that? Jenner's loop.
That's an old term. Somewhere I read that word. No, there is no name for the particular loop, I remember. It is not seen somewhere else. It's not seen in the textbooks now.
Okay, sir, for that patient with the adrenomyeloneuropathy, any treatment was offered? Like?
No, we couldn't give any operative treatment.
Okay, sir.
Okay, shall we stop now?
Sir, in this
Okay,
index
sir.
case, what was the facial pulse, sir? Can you please show the picture again of the patient?
Yeah, sure. Sure.
Just
I'll
I
come
want
back. Yeah, definitely, no problem.
കണ്ണ് മുറുക്കി അടക്കി ഈ
See that?
പല്ലി കാണിച്ചമ്മ ഈ
Only lower part is
മതി
affected.
കണ്ണ് മുറുക്കി അടക്കി മതി നാക്ക് നീട്ടമ്മ
See the lower part.
നാക്ക് അങ്ങോട്ട് വേണം എങ്ങോട്ട് കാണിച്ച് ഇടത്തോട്ട് വലത്തോട്ട് ചലിച്ച് വലത്തോട്ട് കൊണ്ടുപോവാ മതി പറ്റുന്നില്ല മുറുക്കി പിടിക്കുന്നു.
Okay. Typical Sada ordinary human facial palsy.
Sir, the position sense and the vibrations were normal.
Normal.
Medial lemniscus involvement was not.
It was not there in this patient.
And tongue also is spared.
Tongue is also spared.
Tongue is spared or not, I'm not very sure. Because in human facial palsy, tongue may not be affected. Or it's only if it is not all cases, tongue will get affected. In some cases, it can be affected. It all depends upon the percentage of fibers which is represented bilaterally. The maximum contralateral representation is for the lower face. Then comes the tongue. Then comes the parent. So in acute hemiplegia, sometimes you can have a contralateral tongue congenital tongue palsy. Less commonly, congenital palatal palsy also can occur in acute hemiplegia.
So
But they
as this
require,
is a medial medullary syndrome, we expect a 12th nerve element palsy.
this is not medial medullary syndrome. This is the anterior medullary syndrome, not fitting with a medial medulla. So this is not fitting with a typical muscular territory involving all the three, this thing, only the pyramid. Sometimes, the infarct may be only confined to the pyramid. Not involved in the 12th nerve or the medial lemniscus.
12th nerve fibers are passing through the pyramid, sir.
No, it's not passing the pyramid. It is going between the pyramid and the inferior olivary nucleus.
Okay, sir.
I'll show the picture. It's not the picture I brought it for that. I will show. Yeah. So this is the one you see. You can make out here now. That is the 12th nerve. You can see my arrow.
Okay, sir. Yeah.
This is the pyramid. This is the medial lemniscus. Sometimes it may be only infarct compared to this area alone. Only pyramid will be affected. I'll show the picture once again. See this one. It's only in the pyramid.
Which is the artery? It is antispinal artery or some branch of basal artery?
This is a medulla, no? So it's a branch of the antispinal artery.
Okay, sir.
You can either directly from the vertebral or more commonly from the antispinal artery.
Sir, one more doubt about that girl, 25-year-old girl, sir. Sir,
Yeah.
they might have thought of motor neuropathy since the reflexes were depressed, sir, because the quadriceps, though quadriceps weakness was not there, reflex was depressed, still the pattern observed was that of a motor neuropathy, sir. Obturator nerve, the L1 motor radical, and the deep peroneal nerve were isolated and involved without sensory involvement. So since the reflexes are depressed, they might have thought of motor neuropathy, sir. That is why they have worked up for multiple myeloma, POEM syndrome.
Correct. That's the thing. And that's exactly what you said is correct. Exactly correct. That is why they might have went into the wrong direction. But the point is that if there's a selective involvement in the muscles, the neck muscle involvement, do you think can occur with the neuropathy like that? That is very odd. Otherwise, I could agree with you.
Yes, sir.
The adductors are weak, abductors are. That's the 2-3 points very favoring a myopathy. Moreover, patients.
Reflexia is due to muscle spindle involvement in a case of muscle disease.
Yeah, that is possible. That's again possible. But classically, the cortex muscles has spared in GNE myopathy. Okay, so in this patient, see, usually this explanation comes. See, in a myopathy, there is weakness, mild weakness, and the reflex I lost early. You can think of that possibility. Without any muscle weakness, only interfacial affected in a myopathy, you have to take with a caution. That is more likely to be a neuropathy, as the doctor was telling, than a myopathy. For somebody has got mild weakness or just mild weakness and reflex is lost. It is more likely to be a radiculopathy, neuropathy than a myopathy. If a myopathy is producing reflex loss, usually a significant weakness should have occurred, or as you said, a muscle spindle should have been affected. But a myopathy only affecting the muscle spindle without affecting the extrafacial muscle not producing any weakness is quite unusual. Yeah, did you get my point?
Yes, sir. Thank you.
Right. Okay, shall we close today?
Thank you, sir.
Yes, sir.
Thank you. Good night.
Good night, sir.
Thank you, sir. Good night.
Good night. Next week. We'll see you next week.